Okay.
Do you see it?
Yeah, I can see it. Yeah.
Just say start watch party.
I need to find a way where that is. It's not something that I use commonly.
Just share it on your wall. People will take care of it. Don't worry.
How do I share it on my wall?
Just share the whole. It's saying Mohali's live, so just share that.
I can't find that.
Just hold on.
Let me just see. Oh, share.
Yes.
Yeah. So share to your story of friends.
Yes. And then they will see the link.
Yeah. Okay. Cool.
You good?
Yeah, got it.
Ray?
Yeah, I got it. I'm telling you.
Okay. Good evening. Good evening and welcome to All the Facts with Dr. TJ Mohali. It's Friday, the 10th of April 2020. And for tonight, we will be talking all things chloroquine, hydroxychloroquine, and other drugs related to COVID-19. We always start with the statistics. And as of this second, well, not necessarily this second, but the second a few seconds ago when I refreshed, because as I said previously, the Center for System Science and Engineering at the Johns Hopkins University and Medicine is live. This data is being updated on a second by second basis. So as of this moment, we have 1,631,310 cases worldwide. The good news this side, the number of people recovering is doing very well. We have 365,250 cases. So we are now, unfortunately, we are also approaching 900,000 on the death toll. The death toll at this moment is 97,264. Italy remains the hardest hit country. Spain followed by France, but the United States, the number of death toll in the United States is increasing at an alarming rate. So this virus is very serious. Just on a breaking story, it has just come to my attention now. The Review Online, the local newspaper in Limpopo province, is now reporting that Polokwane Hospital, our provincial hospital, is sitting on, it has been isolated. The hospital has been closed. This is after one of the medical officers working in that hospital was confirmed to have the SARS-CoV-19 virus, and he has come in contact with well over 100 people in that hospital. So the provincial government is scrambling to find a way forward on how to contain that issue. This is a big problem for the province of Limpopo because Polokwane is a referral hospital. The Petersburg Academic Hospital is a referral hospital. So the whole province, patients go to that province, so to that hospital. So that province sees people who come from all the 5 districts of Limpopo. So they have to move very fast. The contact number of 100 is a...
This is a big problem for the province of Limpopo because Polokwane is a referral hospital.
Prof, I think I'm hearing an echo on your laptop there. I can hear myself on your laptop, Prof.
Go to
Thank you, Prof. Sorry about that, technical glitches. So I was still saying that Polokwane Hospital is a central referral hospital for the province of Limpopo. And that is a big problem because there are patients who have been to that hospital in the past week who then travel to their local hospitals, and from their local hospitals they travel to their villages. So let's hope, my only hope on this one is that they are doing everything in their power to get the tracing team. The tracing team need to wake up, and they need to see which patients have been referred to that hospital in the past 2 weeks or the past week, most importantly, and they can begin wide area screening. We are going to need extensive screening. Otherwise, the potential of one case in Polokwane spilling to the rest of the province is very easy. So that is just the local update from Limpopo. As you are all well aware, the lockdown in South Africa has been extended by 2 weeks. The President Cyril Ramaphosa announced that last night. Well, most people already had a hunch that the lockdown looks like it's going to be extended because, well, the cases have only been increasing. So with the cases increasing, you don't have an option but to extend. Currently, in South Africa, as you can see here, this is from the John Hopkins. These statistics are supplied to the John Hopkins on a minute-to-minute basis by the National Institute of Communicable Diseases here locally. So we have actually 2,003 confirmed cases. We have 410 recoveries, and we have 24 deaths in the country. And currently, at the moment, we have 1,569 active cases. So we don't have as many cases as most models suggested we could be having. But the question for most people is, are we testing enough as South Africa to say we don't have cases? So the issue of testing is under the microscope at the moment. Everybody wants to understand what is the story with testing. So that is just an update on South Africa. The second update I wanted to give, I said that I will keep an eye on the Nehau case. So the case was brought by the National Education and Health and Allied Workers Union. This is a case pertaining the availability of personal protection equipments around hospitals throughout the country. So yesterday, Nehau withdrew the case. I believe this is after they had a consultation with the Minister of Health and other relevant stakeholders. So I believe they have come to an agreement that I said the previous day that the government is expecting a large shipment from China, which include gowns, which include masks, which include boots, which include visors, which include goggles for the protection of frontline workers. So I believe the Minister of Health was able to convince Nehau that, look, these things are on the way. You have to understand that things are moving slowly and the demand for these items is very high. So I think Nehau is being very mature and is being very reasonable with the Minister of Health. So we can only hope the Minister of Health returns the favor in kind, and hopefully by next week or latest next week Friday, we will not be able to continue working in these hospitals if we do not receive the necessary N95 mask, the necessary personal protection equipment. So that is just a quick update on that case. So without further ado, on this side we have Dr. Ray Muhulisa from the Health Innovation Lab at the University of Cape Town. How are you, Doctor?
I'm all right, man, and you?
Yes, I'm okay. We are just trying to do our very best on the front lines, the best that we can with the resources that we have. So one of the resources that has been touted as with regard to the SARS-CoV-19 pandemic is a drug called chloroquine and another one called hydroxychloroquine. Would you be so kind to tell us what is the story there with these two drugs? What is chloroquine, doctor?
Okay. So both chloroquine and hydroxychloroquine are quinine derivatives for specifically 4-alpha aminoquinoline derivatives. So the story or the history behind how chloroquine and hydrochloroquine got discovered is that during the 1600s, when the Spanish were busy colonizing Chile, they were heavily infected by malaria. However, they found out that the Incas in Chile were using the bark of Cinchona to cure malaria. And this Cinchona bark tree had additional qualities that were described in the pharmacological medicinal properties were described in the 1700s. And what happened is that the British and the Dutch took these plantations in Japan, in Indonesia, in the early 1900s, and from that, quinine was produced. So a gentleman by the name of Professor Payne, who was British, described the use of these quinines for treating systemic lupus erythematosus. However, there was a problem that happened during the Second World War, where Japan occupied these plantations, and that the production was quinine was lost. And then after, subsequent to the Second World War, the United States pursued synthetically manufacturing quinine derivatives. They started with quinacrine, which was a 9-aminoquinidine compound, but they found that this was highly toxic. So from then on, they could, from this 9-aminoquinidine, produced chloroquine and hydroxychloroquine, and they found that they were effective anti-malarials with less toxicity. So that's how chloroquine and hydroxychloroquine came to be used as anti-malarials since 1932 or so. But the pharmacokinetic profile was described thoroughly in the 1980s. So that is the history behind chloroquine and hydroxychloroquine.
So, doctor, how is a drug from 1600 on some tree bark there in Chile. How is it relevant in the year 2020?
So it has. So both have been touted as that they can be used to treat coronavirus. So the reason why these two drugs have been touted to be to sort of like being used to treat chloroquine and COVID-19 is because of their ability to bind to the red blood cells. So those of you that know that are aware that red blood cells are responsible for transporting nutrients in your body via heme when oxygen is bound to iron. So what happens is that both chloroquine and hydroxychloroquine bind tightly to red blood cells to ensure to sort of like disrupt the life cycle of the red blood cells. And thus, if for instance, a red blood cells is infected with COVID-19, what will happen is that chloroquine and hydroxychloroquine will disrupt sort of like the life cycle of the red blood cell. And what will happen is that will force the red blood cells to burst open, and the virus will be open to sort of like antibodies that are in the environment, and in that way it can be sort of like killed. So that's why they're sort of like proposed to use chloroquine and hydroxychloroquine. And by the way, these two are readily available in pharmacies, and that's why. So that's another thing.
You are saying they are? Doctor?
In pharmacies.
Or they are easily available in pharmacies?
Yeah, so they're easily available.
Okay. So you are saying they're easily available. On this other side here, just hold on, doctor. Yes, we have Professor Rana Kwelihluenya from the Department of Dermatology at the University of Cape Town, senior lecturer at Groote Hospital. So, good evening, Prof.
Hello, Ntate, how are you?
No, I can't complain any more than I already have.
It's difficult times.
Yes, you just heard Dr. Moholisa giving us a historical background with a little bit of chemical background of chloroquine as we know it. You are a dermatologist. I heard him mention systemic lupus erythematosus. So that is something that you treat. That is a disease you treat on a daily basis. Dr. Moholisa here is saying chloroquine and hydroxychloroquine are easily available in the pharmacy. I read somewhere yesterday where you were saying the patients that you are prescribing chloroquine and hydroxychloroquine to are finding it difficult. When did it become difficult to get hold of chloroquine and hydroxychloroquine, which according to our doctor here should be easily and readily available, Prof?
Over the last week or so, I've had 4 patients. It's not a problem in the state sector. The hospitals are well stocked, but the problem is that in private, it's not available. So I've had patients with quite serious, severe lupus, which I've had to refer to the state sector to actually obtain chloroquine. And the thing about it is that this chloroquine is an integral part of treatment of not just only lupus, of rheumatoid arthritis, Sjogren's disease, and many other connective tissue disorders. And there's a massive number of people who need chloroquine. from day to day. And this has been going on for a long time. It's an affordable drug, it's reasonably accessible, and it's a very, very useful drug. The problem with all these conditions is that the only other alternatives really that are effective are systemic steroids, which obviously have got quite bad side effects. On the other hand, you also then have to use things like biologics, which are quite expensive, which are not accessible to most of us, whether you're in the private sector or in the public sector. So the problem is that the furor and this hurry to stock chloroquine is actually affecting a lot of people who actually fundamentally need the disease. And there's very, very good studies. The thing about this is that the use of chloroquine in connective tissue disease has been there for a decade. There is no good studies that were done initially, but over the years, systematic reviews and experiences that have been shown, it's been shown that it's an extremely effective drug, and not just for lupus, for rheumatoid arthritis, for Sjögren's disease, for dermatomyositis, and other important diseases. So it's an important drug, and I think for people who are holding the drug with the hope that something may not happen to them, in the process, taking it away from people who actually need it is wrong. And I think that this is just not applicable to the doctors who prescribe these patients for patients who need it, but it's also important, it's not just the patients, it's the patient, people who go and get it when they don't need it, it's the doctors who prescribe it for non-clear reasons, and it's for the pharmacist who actually issue it. And then one of the things that I was hoping that we could suggest is that there are Schedule 6 drugs that you cannot get, like Ritalin, which have got to be signed. You can only get it for a month, and you've got to provide very good evidence why you are doing it. And I think that at this stage, if things went my way, it would be scheduled to a level that if you have got to prescribe it for a doctor for an indication that is not well established, then you are effectively lying and you're committing a crime. But on the other hand, for example, as dermatologists, we use it for something, a condition where you lose your hair and your eyebrows. That is called frontal fibrosing alopecia. It helps remove the pigment, it helps slow down the loss of hair. But at the moment, I've actually stopped prescribing it to my patients for that purpose because it's not life-threatening. I know it's important for people's mental health to have their hair and not to lose their eyebrows and not to go darker. But in the context of having to choose the use of a limited drug for people for whom it's a matter of life and death or a matter of severe functioning, renal impairment, mental disorders, heart problems, and all the other disorders that are associated with connective tissue diseases, as versus our patients who need it for hair loss. It's a choice between zero and nothing. We would rather reserve it for those people who really need it. And I think in the feeding scheme, on that value chain, people who are stocking it just for the sake of possibly being useful for coronavirus is not very useful. And just to add on to that, I mean, the use of chloroquine for viral infections started a long time ago. In fact, the very first in vitro studies that were done for the use of chloroquine was for infectious mononucleosis. Infectious mononucleosis is caused by Epstein-Barr virus, and we know now there's no treatment for it. But one of the first studies that were done was the use of chloroquine for EBV. And in that studies in the lab and in animal models, as in any other viral infections, it was found to work. But then when you then transfer it to humans, then it has not been successful. And if you go back into the literature, it's not just EBV, it's not just corona, there's multiple other viruses that have been tried, both hydroxychloroquine and chloroquine. And obviously in South Africa we use mainly chloroquine because it's cheaper. Hydroxychloroquine is safer, mainly for the eye complications, but we mainly use chloroquine rather than hydroxychloroquine, mainly because of cost. So it's a very important, and I would advise people to go back and look at the history of chloroquine and studies that have been done that actually explain the myriad of studies that have been done to try to see if hydroxychloroquine and hydroxychloroquine work in viral infections. And there are many, many of them. And up to this day, none of them has shown any benefit. Remember that in any setting, you develop hypotheses. You test that hypothesis. Hundreds of hypotheses are developed in the scientific world every single day, and the majority of them fail. You think it will work in the lab. You think it works in the lab. It works in an animal model. You put it in patients. It doesn't work. In fact, in some cases, chloroquine has been found to make viral infections go worse. For people who have to face this patient, have to take somebody who is a private patient who has a medical aid. Yesterday I had to refer them to hospital, get them to become a hospital patient so that they can access chloroquine because they've got renal lupus that affects their kidneys. So it's why it's an important issue.
So, Prof. Yeah, Prof. You have said a mouthful, but I just want to stay with you for a moment. We are saying, you said people are stockpiling chloroquine. That is a fact, because people heard that it works or may work against coronavirus. I know you watch the news, Prof. Every night when you are watching the President of the United States in his daily briefings, the word chloroquine, the word hydroxychloroquine are always in his speech. And what our leaders say usually stick with the people. I have been reading from the American media that they are seeing people coming into hospital with chloroquine toxicity, with hydroxychloroquine toxicity, because they are taking a drug that they don't have an indication for. They don't have coronavirus. They don't have any connective tissue disease. They don't have malaria. But people are being admitted to hospital due to chloroquine overdose. Any comment on that, Prof? Are our leaders misleading our people?
Again, it's in times of danger. There is, I think, for many people, the sense of self-preservation supersedes everything else, and many people tend to forget about everybody else. You tend to think of self first, and that's where regulations are important. Chloroquine, under most circumstances, is a very safe drug. There are a lot of drugs that are less safe. The major worry that we've had over years is a cumulative dose that people would have when they use chloroquine for the eyes, and then it can get eye damage. Sometimes it binds to your melanin and it can make you darker. So those are, as a drug on its own, and hydroxychloroquine, it's not that important. But then sometimes there are other drugs that it interacts with, and if you take this and you get it access to it, not under proper supervision, it becomes a problem. A classic example is somebody who is in digoxin for heart failure. You would know exactly how small a range of use digoxin is. It's a very narrow range of dosing that you have. You go anywhere above that, you run into major problem of digoxin toxicity. Chloroquine increases toxicity or the blood levels of digoxin almost 4 times. So if you are going to a pharmacist, you are going to a GP, you are going to somebody who is using the drug without a better understanding of the implications of the drug and what the drug means, you are probably putting yourself in danger. And the problem is that you are putting yourself in danger at the expense of people who actually need the drug. And I don't have evidence that people are holding the drug because I've not seen anybody. But the problem is that it's not available where you need it. And we have never had this problem before. So somebody would know, the medical aides and the legislators and the government would know what is happening to the stocks of chloroquine that is necessary. But a good example is exactly those people. And it's not just the digoxin. There are other drugs whose metabolism is affected by chloroquine itself. So it is an important, and again, it's difficult to comment about leaders and politicians. People have vested interests. Economists want the economy to go. Doctors want all of us to go together, and it's a balance between that. But some people have got monetary aims that they have in relation to that. And I don't know if that is the case. People would want to make as much money as possible. And sometimes, because chloroquine is such a cheap drug, if as a manufacturer you can make that much money out of it in one go, most people would in business, many people in business would be tempted to do that. Let me not say most. So it is an important thing for us to consider. And the thing again is that if you look, there have been a whole lot of publications over the last 3 months that describe the utility of chloroquine in COVID-19. Now, if you read the summary and you read an abstract of that, as an inexperienced person who really looks at how the study was conducted, what the endpoints were, what is it trying to prove, what are the limitations of that study, and having gone through many of them, I would not use it for myself because they are not very robust study. And the thing is that it's not that it will not work. There is not enough evidence to support that it will work. And from my personal perspective, the previous experiences, which is accessible to everybody, if you go back and you look at the use of chloroquine in viral treatments over the last 40, 50 years, it has not really translated effectively in humans for virus treatments, not even once. So as a betting man, I probably wouldn't take the odds of this one succeeding.
Okay, just hold on, Prof. Let's bring in Dr. Mhulisa. I can see he has a lot to add on to this. Doctor, you are a researcher and you do research in the medical field. President Donald Trump has been asking most of the questions about chloroquine, while one of the world's leading infectious disease practitioner expert, Dr. Anthony Fauci, is there. So Prof. Ranks here just told us that there is not enough evidence that it will work. As somebody who does research, how much research do we need to say this drug will work, this drug definitely works? Because right now the statement from the FDA in the United States is that, look, at the moment it is compassionate use. If there is nothing else that you can use, if the patient in your clinical assessment, the patient might demise from the virus, there is no really much harm in trying this drug. So you can try chloroquine. So there is, as Prof just said, there is no conclusive evidence that it works. Just to add on to that, I've just learned that India produces 70% of the world's hydroxychloroquine. There are more than 30 countries which have put in an order for hydroxychloroquine. 30 countries, not hospitals, countries from around the world. 2 weeks ago, India had a ban on drug exports, but for humanitarian reasons, India has lifted their ban on drugs and other supplies so that India can be able to supply the world with chloroquine. So how many studies do we need to say conclusively this drug works, holding this drug is the right thing to do, and for doctors in the periphery treating the patients with COVID-19 with drug is the right thing to do. Yes, doctor.
So as per Prof. Leclerc's submission, I absolutely agree that chloroquine and hydroxychloroquine have no antiviral activity. It has been shown. So the premise of chloroquine or hydroxychloroquine being prescribed it's solely for its ability to disrupt the red blood cell cycle. So you will need tons of studies, multi-center clinical trials to confirm whether hydroxychloroquine is effective for treating COVID-19 or not. And I might say, people will be disappointed. It's not gonna. It's gonna prove to be controversial. It's gonna prove not to work because so many of his biochemistry or his pharmacology, and the reason why in the U.S. is controversial with regards to Dr. Fauci is because, as Prof. Leclerc has said, both chloroquine and hydroxychloroquine bind to eumelanin, and eumelanin is present in Africans at a higher degree compared to any other race. So you are bound to have toxic effect, especially of the skin, due to usage of chloroquine and hydroxychloroquine. So further studies need to be done, but I do, however, have a concern that those studies are not going to prove to be conclusive, or actually they're going to prove to be actually useless.
What would you say if you... Yes, Prof. Yes, Prof. Go ahead.
I just want to add something. In desperate times, we break rules. We break rules of research. And ideally, you would do a randomized, double-blinded trial, multi-center. But if today I get 30 patients in a week and I give all of them chloroquine and their symptoms disappear in 2 days, completely they're gone, and there's no need for ICU, I would recommend it. So the context is always important, and the efficacy of the drug and how well it works is important. If that drug, like I said, if in China they would have used chloroquine on 30 patients, all of them shortened their hospitalization by 90%, and they walked out of hospital every day. Even if that data was not robust and was not the best quality study, it will give you, in this setting of an emergency, a reason to try to use that drug as possible. Because there are certain things that you use immediately, and even within a very small population, you find that they work. Therefore, you are more likely to find that over an extended time, they will work. And so it may, if it worked that well, and it works that well, considering that there are more than almost 1 million people worldwide who are affected. And if those of them who have received it, and you find that it made a tremendous and easily observable and detectable difference in 90% of them, or even 50% of them, I would not hesitate to give it to my mother tomorrow. So the studies that are necessary will depend on the agency of the situation, and this is a critical urgent situation, but it also depends on the benefit, the detectable benefit of that study. If it's got a very small benefit, it takes 100,000 of them. You would have to treat 100,000, maybe you would have to treat 20 people to get one benefit. But sometimes, if you're going to find that you treat 5 people and you get a good result, and a detectable good result in 3 of them, having tested 50 people, that would be a reason enough for me as a clinician. When I look at that data, I can go back and say, this data is quite robust. This is quite promising. Until we do the other clinical trials, I would then suggest to do it. So the issue of clinical trials and how long it takes in the context, I think is very important. This is an abnormal situations, and the standard rules of research in the use of drugs will be broken. The velocity at which journals publish papers is broken all the time. People submit papers, they're published within a week. The problem with that is that inaccuracy is creeping. But that's the nature of the situation. You would rather have tried rather than have made a mistake without never having tried to find a solution.
Okay, thank you, Prof. Dr. Mholisa, what's happening in the solidarity study that the WHO keeps on talking about on a daily basis? They say they are investigating chloroquine, hydroxychloroquine, azithromycin, and protease inhibitors in the form of filapinavir, remdesivir, lopinavir, ritonavir. So they are saying we should be having the results of that study very soon, because as Prof just explained, if you want to see if whether remdesivir is working, you just need X number of patients and you treat them. And as he mentioned, with 1.6 million people affected around the world, we are not in short supply of patients. Yes, Doc.
Yes, so I mean, it would be interesting to look at those results as to, so because I mean I've read what they're currently doing. So it would be interesting to see as to, because with antivirals they're using, as you rightly put it, ritonavir, lopinavir, and remdesivir. So it would be interesting to see with the combination therapy of either, because I mean I wonder how the study was designed, right? Maybe they will explain it in the paper. But it would be interesting to see the combination of lopinavir, for instance, an antiviral and an anti-malaria, which is chloroquine or hydroxychloroquine. The combination of those, how effective is it compared to the other, right? How effective is a combination of lopinavir and azithromycin compared to chloroquine or hydroxychloroquine? How effective is those treatments? So, because at least from there, we can sort of like make informed decisions as to how to treat COVID-19 going forward.
Okay. So at the moment, we don't have the answers.
No.
We don't have the answers. At the moment, just to use Dr. Fauci's words, the evidence is anecdotal. So that's where we are basically at the moment.
Yes.
Prof,
Yes, sir.
as I said when I was giving an update on the Nahau case, one of the supplies that Minister of Health, Dr. Zweli Mkhize, said he's getting is that he went into length about this, talking about how Minister of Trade and Industry, Minister Patel, has managed to convince India to make sure that South Africa's stock of hydroxychloroquine is exported, restrictions or no restrictions. So, do people just want to be seen like they're doing something?
Look, the problem is that we are in very uncharted territory. We as a leader, as a government, you've got to have your population's vested interest at heart. And there's a sort of saying that the first one to get anywhere will get the fattest worm. So if chloroquine works and we don't have stock of it, then we need problems. If any of the antiretrovirals work and we don't have stock of it, we're in trouble. If protective gear is running out of stock and the government does not make provisions early enough to supply it, we'll be in trouble. So sometimes I would rather say that be brave, do something and make a mistake rather than do nothing and be foolhardy and suffer the consequences. I think in this instance, for me personally, the consequences of a committed action would be much, much better than the consequences of an omitted action. If you did nothing and it turns out to be, you will have regrets. If you spend money and effort and you get all of those things into the country and it turns out it was not necessary, the drug doesn't rot. We can still use it.
Okay, I understand your message there, Prof. So we must buy chloroquine as a country, but we must understand that the evidence is anecdotal. As you started by saying, patients are needing chloroquine. So even if we buy a lot of chloroquine, we will use it for malaria and we will use it for other conditions. That's your message. But we must wait for the evidence on coronavirus.
Yes.
What is your message to general What is your message to general practitioners prescribing chloroquine?
Again, I says that when a good example is how you ration ICU beds or renal dialysis. If you have a 93-year-old man with diabetes and cancer who needs an ICU bed versus a 20-year-old healthy man who was hit by a car by a drunken driver, and both of them need an ICU bed. You have to make those ethical and moral decisions as a doctor to rationalize the limited resources. At the end of the day, as a doctor with access to limited resources, you use your resources wisely so that you get a bang for your buck. If you're going to store them for somebody who doesn't need them, you are not getting a bang for your buck, because at the end of it, if it's proved that there's no benefit to them, they go straight to the bin. They won't return it to the pharmacies. Pharmacies don't accept return medication in this era where we are getting an upsurge of counterfeit medication. So what's going to happen to those drugs? They're going straight to the bin.
No, I understand, Prof. No, thank you for your time, and we hope that next time when we would like to talk to you about all things coronavirus, you are able to make your time. Thank you, Prof. Enjoy evening, Easter evening.
So much. All right.
Bye-bye, Prof.
Bye.
Doc, you spoke about the study design, that you want to know about the study design of the Solidarity trial. Are you happy as a researcher in the medical field about South Africa's efforts in fighting the coronavirus? Are we doing enough? Are we doing enough research for ourselves? Or are we waiting for somebody to bring this evidence that you say we need so badly?
I'm happy on the decision-making side with regards to the lockdown, how it was done, right? It should have been done sooner rather than later, but anyway, it's done. But with regards to what we're doing in research, I'm not happy at all. We're not doing enough. It seems we're waiting for evidence to come from elsewhere, whereas we do have capacity here at home to do research. I don't think we're mobilizing enough researchers to do work in this regard. So in terms of what we're doing in research, I'm not happy at all.
If you were to give advice, if the Minister of Health or someone from the COVID-19, South African COVID-19 task team was to ask for your advice and say, what do we actually need to do scientifically, what would you say?
I'd actually say one. I mean, I'm impressed by the work that has been done at UWC and in KZN of sequencing the genome of COVID-19, right? So that is done. But now on the treatment side or the treatment front, nothing is done, right? I do not know at present on the equipment. I know, from a colleague that they said at Tigerberg Hospital here in Bells, Cape Town, they're using erythromycin and chloroquine. But what's happening elsewhere in the country, I do not know, right? So how do you advise somebody where there is no information available on a public platform what is being done, where us as researchers can chip in and help and say, okay, with regards to this is what we think will work or not work, right? Because the drugs that are proposed, they're already available clinically.
We have been, for example, as you are saying, I don't think anyone in the world has more experience than South Africa in the use of lopinavir, ritonavir. That is an ARV we use for children. I don't think any people in the world are drinking more lopinavir, ritonavir than South Africans.
My PhD thesis actually centered around lopinavir and nevirapine. So I know more about lopinavir, ritonavir.
So how do we harness this? How do we harness this knowledge? We, like you are saying, like I just said, we have a lot of experience on those drugs. Remdesivir is a new one. We don't have a lot of experience, but the drugs that we do experience, we treat a lot of malaria in South Africa. There's no malaria there in Europe. There's no malaria there in the United States, but not as much as we have here. But somehow we are waiting for them to make the research for us. In monetary value, how much is actually needed to conduct these studies? Because maybe we are just preaching to people who think these things are more expensive than they actually are, Doc.
The drugs are already there, available, right, clinically. What is disappointing, or what I find disappointing, is as what you said, is it seems we're waiting for research out there to confirm research for us, and then we are just going to follow. Why aren't we doing research ourselves? Why aren't we harnessing our own local researchers, or even sort of like saying, hey, local scientists, those that have experience in antimalarials, antibiotics, antivirals, please, here's a task team, contact this person so that we deal with this. We submit proposals as to how we deal with COVID-19 properly. It's not done. It seems we're waiting for research that is coming outside, which has been found, or in my experience, what I found that you'll find that there's a study done somewhere. You try to replicate the same findings here, you find that it's completely different. What you find is completely different because it's a different population altogether. So it seems we're still using either Europe or America as a standard, whereas research has shown, beyond reasonable doubt, that because we are different genetically, so what works there is not going to work here. So it's on that front, I don't think we're doing enough, or we're not doing anything at all. In terms of the cost, I don't think it's going to cost that much in terms of now saying, okay, we have ritonavir here, let's try it in patients, let's do a study. We try it in what, 10, 20 patients, and in combination. That you're looking at a cost maybe to do recruitment, analysis. You're looking at a cost of, say, I'm willing to offer my services for free. Maybe the only people there will probably have to pay are the participants themselves. So you're looking at the cost of, because it's critical time, even medical doctors in clinic will probably easily volunteer. We're looking at easily at a cost of maybe around 200,000 to conduct a small study.
So if we had 200,000 right now, we, like you already said, we have the laboratories. This is a public crisis. There is no need to be paying university laboratories to do work that is in the public interest. So we are just not doing it. That is our conclusion. Okay, Doc. I think we have said a mouthful. Tomorrow is Saturday. You already said you are happy with the lockdown. So tomorrow we will discuss the mathematics of a lockdown. We want to look at there is one study that came from India. Unfortunately, it is the only available study that is that is being quoted around the world. So let's critically appraise the study. We will have a mathematician with us who will help us understand. I understand you were building such models so in your PhD. So let's hope that you have looked at the study and read it over and over again and fully analyzed it so that tomorrow in the afternoon we can critically appraise the mathematics of the optimal duration of a lockdown.
All right.
No.
So there's another paper that came out yesterday that was done using the data that is available from the WHO as to how long, I mean, the duration of infection, how long is it gonna take? And I mean, the effect of lockdowns, such. So I mean, it's going to be quite nice to discuss both papers. I don't know if a mathematician will be ready to quickly go through the maths
he has prepared on the first paper, but do forward me the second paper, and he will just have to look at it. If we decide to do it on Sunday, that is still possible. It's a long weekend. Everyone is on a lockdown. As I keep on saying, this content is very long. There is no way of summarizing chloroquine. There is no way of summarizing the mathematics of a lockdown. So let's hope we can be able to discuss it tomorrow afternoon, Doc.
All right. Thank you.
No, thank you. Enjoy your Easter evening.
All right.
Bye-bye. See you tomorrow.
Cheers.
That was Dr. Ray Muhulisa from a postdoctoral fellow at the Health Innovation Lab, Data Science. So he works with data, has a lot of experience in both genetics and pharmacology. So that was our discussion on chloroquine and all things hydroxychloroquine. You have heard the message. We need more data. We need more studies to learn and fully understand and have evidence beyond a reasonable doubt. In law, they speak of beyond a reasonable doubt. It is very difficult right now to go beyond a reasonable doubt, but at the very least, we have to conduct our own local study. We have to contribute to the international body of knowledge. Body of knowledge just means, like you just heard Dr. Ray now, we'll be discussing a paper tomorrow about the mathematics of a lockdown. Yesterday, another paper came out from elsewhere talking about the mathematics, the optimal duration of a lockdown. So that is people contributing to the body of knowledge. We owe it to ourselves. We owe it to the world to contribute. Coronavirus is in every country. There are scientists in every country. There are researchers in every country. So every country should be bringing their own evidence. We can then do a meta-analysis of that data from different countries and say, you know what, stay away from chloroquine. Or say, you know what, chloroquine is the best treatment in combination with XYZ for the management of COVID-19. We all want treatment. But the first line on the Hippocratic oath, which most of us took, says, do no harm. So we cannot give you drugs that are harmful. All drugs have side effects, but some drugs have more side effects than others. So it is important that safety comes first. As the President of the United States keeps saying after he was challenged, we cannot let the cure be worse than the problem itself. He just means we cannot let people die of side effects of a drug trying to treat COVID-19. So we need this data. We need to make sure our leaders understand that the bullets in this war against COVID-19 is not necessarily drugs, but it is science itself. It is data. It is randomized, double-blinded studies. So I started today by saying that my former hospital, I did my internship in Chloroquine, has been put under lockdown or quarantine of some sort to try and figure out what is happening there after a doctor was diagnosed with coronavirus. You are well aware of what is happening at St. Augustine's Hospital in KZN. It's a private hospital under Netcare. It has also been put under lockdown because more than 67 people, 48 of whom are healthcare workers, tested positive for COVID-19. Now, here is what I think. Do not move patients out of St. Augustine's. Test those who are negative, move out. Isolate everyone, socially distance everyone. Those who test negative must move out. Convert the hospital into a KZN provincial coronavirus center. I know the hospital belongs to Netcare, but this thing can happen to anyone. It's not like Netcare did something. It's not like Polokwane Hospital did something. If you look at the news and you look at the data coming from Italy, it is very easy for a hospital to become the epicenter of coronavirus. Hospitals in Italy were supposed to treat, at the beginning, you say we are isolating. Half of this hospital is treating coronavirus, half is treating patients without coronavirus. You can carry on that for a while, but some things happen, and a hospital itself, it's an easy target to become the center of an outbreak. Why? Because we are treating the deadly virus. The virus moves, people move. It's impossible to know who took the virus from who and who took it from who. But what we know is that St. Augustine's Hospital in KZN is an epicenter of coronavirus in that province. The hospital has resources. I think Netcare and the Department of Health in KZN should come into an agreement, and that hospital immediately is turned into a coronavirus center. And patients who are negative are moved to other hospitals, and the hospital is used for the duration of this crisis as we can't close it down. It doesn't help anyone to close a hospital right now. We need hospitals. That is what the Prime Minister of New Zealand said. She said it is not in her best interest to fire a health minister for breaking the rules because we are fighting a virus. Maybe she will still fire him after the virus. I understand everyone want to see justice done, the law. Yes, those things must happen. But what do? You cannot close down St. Augustine's Hospital. That is one less hospital in the system. The system is already stressed. The system is at a breaking point. We need all available hospital beds. I hope the epidemiologists who have been appointed to figure out what is happening in Polokwane can do so in a matter of days. Limpopo already has the Mulimula Center as our as our isolation hospital. So we still need Polokwane for other cases, unfortunately. So let's find out the answers. And this speaks to testing. I said the other day that in Israel, the state of Israel, the country Israel, is testing all healthcare workers every 5 days. If you don't test healthcare workers, you are not only putting their colleagues at risk, but you are pushing patients who are coronavirus negative at risk. How am I supposed to know right now? How am I supposed to know that I have had coronavirus? I never had any symptoms and it has resolved. That is one of the problems with coronavirus. You can have it, be asymptomatic, go around spreading it. So, unfortunately, these two incidents, the St. Augustine incident and the Polokwane incident, are telling us that we need to test all healthcare professionals, as in yesterday. And then that way we can know who is negative, who is positive, and we can take the right course. As we keep on repeating, policy is informed by data. Data is informed by research. So we need to quickly do the research and find the answers that can inform the policy. Thank you for watching All the Facts with Dr. TJ Mohale. A big thank you to Professor Rana Goele from the Department of Dermatology, Groote Schuur Hospital, University of Cape Town. A big thank you to Dr. Ritzilisito Mohulisa, Data Science Postdoctoral Fellow at the Health Innovation Lab at the University of Cape Town. And thank you to all our viewers. Thank you for tuning in. I'm sure you have questions about chloroquine and hydroxychloroquine and drugs used for COVID-19. It's all experimental. Do not go out there and look for any of the drugs we are mentioning. The studies are inconclusive, and these drugs are scheduled substances that require a licensed professional to prescribe and issue. These drugs have side effects. They are not common, but when they do happen, they can be fatal. So this video will be available on YouTube, hopefully by the morning. If you did not watch it from the beginning, do not despair. This video will be on our YouTube channel. Tomorrow afternoon, as we have already said, we are talking the mathematics of SARS, of a lockdown. On Sunday, we will talk about the proximal origins of COVID-19. The conspiracy theorists must all tune in and hear what the data is saying about SARS-CoV-19 and how the virus might have come about. This is a pandemic. It's all our responsibility. Wash your hands and take care of yourself and your loved ones. The best way of doing that is staying wherever you are. If you are in Gauteng, stay in Gauteng. If you are in Northwest, stay in Northwest. We will all meet and the better days shall return. Thank you. Enjoy the lockdown party on TV and do not go outside. And please don't fight with the police. COVID-19 has killed 24 people according to Johns Hopkins University in South Africa. The health department is still saying 20. So hopefully that discrepancy in those numbers will be addressed in the next few minutes as we have all the confirmed tests. So please stay indoors. Stay indoors. Wash your hands. Good night.